If it's hierarchy, that is power.
Yeah.
One human over the other.
Yeah.
It is detrimental. History, as well as any circumstance in life, shows that partnership is the way to interact in human conditions. And I would not only in the situation, but also in the clinical scenario, but also on a system base. On system-based analysis, oppose such hierarchy. My personal experience in the US has not been that way.
Right.
It is possible that my upbringing as an anesthesiologist was determined by a contract, basically, between two specialist groups, where one does surgery and the other one does medicine, including anesthesia, and both meet in the middle where they negotiate interfaces. At the same time, I can't imagine that maybe there are situations in both countries or both cultures that actually can lead to power struggles. But I would not necessarily say those are patterns that I would associate with a particular culture. Actually, the longer I'm thinking about this, I would actually say that the European colleagues that you may have interviewed could also be a subset of anesthesiologists that have been maybe socialized and transformed in environments that were academic, and those tend to be less, at least less prone to these simple power struggles, one person over the other, at least in my experience.
Yeah.
And more guided by clear contracts between different groups.
Yeah, I think that is a very good point. Yeah.
At the same time, I can see that there's one element that makes maybe the American system of medicine a little bit more prone to hierarchy of a malignant way, and that is that the economic drive behind the medicine, medical subspecialties, would determine the power divide, in that the surgeon brings the patient and the anesthesiologist helps the surgeon. In other words, the anesthesiologist is economically somewhat considered as dependent on the surgeon.
Yeah.
If that is the case, that's ill-conceived. Makes the system prone to harm to the patient.
Yeah.
Because I think the anesthesiologist needs to be
empowered,
is essentially independent,
and
the patient advocate.
Yes, indeed.
And I would actually say, rather than empowered to be the patient advocate, but I think liberated and free to take the position as a patient advocate.
Yeah, absolutely right. Yeah. But I mean,
so in that sense, the anesthesiologist needs to take the position of the free man, not asking for empowerment, but actually
no, you're right.
Liberate.
Absolutely, absolutely right. But I mean, given that sort of false scenario that you just outlined, where the economic power influences the system and that causes a malignant hierarchy, that's your words, in those circumstances, one can actually see how we get into this difficulty of overuse of muscle relaxants and disinterest in the possibility of accidental awareness because of overuse of muscle relaxants, and the use of muscle relaxants being one of the key characteristics of the anesthesiologist's perception, rightly or wrongly, of the expectation of the surgeon.
With some reflection, I would say that that is a little bit of a far-fetched argument. I can again imagine a scenario where you could have that happening, but I would say that all anesthesiologists that I know and that I interact with do have the personality to not use a muscle relaxant because as a consequence of that type of a power struggle. I do believe that anesthesiologists and physicians in general are driven by a very important goal, and that is to relieve suffering, among that relieve pain and help the patient.
Sure.
And the surgeons also have that goal and only that goal. So I think that by trying to do the right thing, traditions may go in a direction that are not ideal for the outcome. If you go and look at the comprehensive outcome, you may do certain things better, but then you have side effects that you do not want.
Sure.
And I think it's humans have both abilities to do things very, very well, and then also to reflect whether what they see as being a good outcome is comprehensively also an optimal outcome. And then at times there are these inflection points where we need to readjust because we have new knowledge and readjust our practice in what way or soever you're thinking. It could be the airline industry, it could be politics, it could be medicine, that we learn from what has happened. I think that the use of muscle relaxants by anesthesiologists, plus or minus with the input of surgeons, has happened with good intent. And yet I can easily see that they can be overused and they can cause negative side effects that we do not intend, and we have to readjust as we have to readjust other things that we do in good intention. For example, giving anesthetics to children, which we have learned over years to do, and these children are extremely safe now under anesthesia.
Yeah.
We have managed that over 30 years, 40 years, to actually survive virtually every child that has the needs for anesthetics. We maintain blood pressure, they live after anesthesia, they enjoy their lives, and yet we do have concerns right now that if we give too much or too long or too many anesthetics, we may actually injure them. And so it's a readjustment of practice. I see the same thing be true for paralytics.
Yeah.
I do think they have a role. I do believe that if we step back and look at our practice, we can readjust. But I do think that the main intent by all physicians is to really help the patients.
Yeah. Just returning for a moment to this issue of muscle relaxants and the perceived expectancy of the surgeons, what about the advent of robotic surgery and the need for absolutely stable operating conditions for the surgery because of the way in which that happens?
Yeah, I think most of the robotic surgery does not necessarily need muscle relaxants on board. Now, it could be a situation where you would need that. I believe if you use a drug, I think the key thing is, so let's say the preference is in a certain scenario, let's say the preference of the surgeon is to have muscle relaxants. Let's take that case. I think it's not per se in any ways an unsafe drug to use because it's used every day in millions of cases worldwide. You need to have certain preconditions. One precondition is obviously giving only as much as you need to give. Never give it without an anesthetic. And thirdly, never use it without a muscle nerve stimulator. Basically an endpoint that gives you evidence of how much is on board, how much do I need to give now, is it a full dose, a half dose, a quarter dose, if I maintain a certain level of muscle paralysis for an intervention. But to tell you the truth, there are lots of operations where actually the surgeons explicitly don't want muscle relaxants on board because it limits the ability to have feedback that they would like to see, and that is muscle contractions if they operate near nerves, for example.
Right.
I believe what we do, we have learned that 50 years ago we need a cardiovascular monitoring when we give anesthetics, because we know giving an anesthetic can kill patients, actually will kill patients if the anesthesiologist walks out of the room.
Sure.
So we have heart rate monitoring, we have blood pressure monitoring, we have oxygen saturation, we have end-tidal CO2 if the patients are ventilated. We have through certain professional organizations clear standards for monitoring, and the use of anesthetics requires that. Now the use of muscle relaxants should then logically also require certain monitors, and there are monitors that can be used, and with adequate monitoring and adequate precautions, I do believe that we can pretty much give any drug that is established in medicine if we understand the implications.
Right.
Just two quick questions expanding on two topics you already talked about. One will be the delirium issue in older people, and the other will be anesthesia for infants, which for many decades was felt to be just muscle relaxation because they couldn't tolerate it. Historically, how did that happen, and how was it resolved that we now give full anesthetics to neonates?
Yeah, let me focus on that question. Providing anesthesia to neonates or young children was a challenge, because these are very, very fragile physiologic systems, if you will. They don't tolerate the same doses that you would give to adults. They have a physiology that is different. The regulations, the coping mechanisms to maintain blood pressure, heart rate, and ventilation are different. I think in early years it was also difficult to monitor certain vital signs. And the worries were high that if you give anesthetics with all these very potent effects on the cardiovascular system, you would actually have an outcome that is contrary to what you want, and the patient's brain would be damaged because the blood flow wouldn't be adequate to the brain or to the heart or kidney, and people may have made decisions to actually use muscle relaxants, for that matter, to provide the safest form of anesthesia as it pertains to the homeostasis of the patients, ventilate them through it, and then allow them to recover. Over the last 40 years, 50 years, the community has managed to actually provide anesthesia using anesthetics and pain medication in a way that now can be considered very, very, very safe. And so, that being said, now the focus becomes a more narrowed focus on outcomes that were not in perspective when 20 to 30 years ago people would be in the process of developing anesthetic regimens for kids, where the survival of the patient was really the main concern. Now we are looking at long-term neurologic impairments, behavioral alterations, cognitive impairments that could potentially result from the use of anesthetic drugs when kids are in certain periods of their development. I think it's a historic, we are just like little blips in a long period of history. I mean, if you look 250 years ago, what people did at that time, nobody would do a surgical procedure in a child. They would simply die. Now we do a lot now, and we have had 50 years ago other challenges. Now we have these challenges. I think nobody uses, no one on the planet uses muscle relaxants without anesthetics at this point. And if so, it would be a mismanagement of that patient, no matter what the age is.
Okay, so and then briefly shifting, and we'll stop. Going back to the delirium issue, we've had different expert opinions on this today, and it's gone from totally unclear, give you regular anesthetic, keep them asleep, keep them unconscious, to very serious issue, we need to paralyze them, keep them light, and target amnesia rather than unconsciousness. Where do you fit in that spectrum?
Yeah, my position is, number one, reflecting back on the need for research. We don't know enough, and until we don't know enough, we shouldn't necessarily change what works reasonably well. In other words, we are providing anesthesia to people with the target to have them be unconscious and pain-free and able to survive, with or without the consequence that certain procedures result in people being going through a phase of delirium afterwards. We don't know whether the anesthetics are really the origin of post-op delirium, or whether in fact surgery is the problem. That being said, I think I would not at all aim for a lighter anesthesia. What I would do is, I think I would avoid burst suppression levels of anesthesia for sure, because that's tremendously non-physiologic. I think from a physiologic standpoint, we accept that 90% of all brains, when they are anesthetized, are still operating. They're operating differently, and that causes this level of anesthesia. We do know that burst suppression is not necessary for the state of anesthesia. In fact, I would say that's on the extreme end of the spectrum and not necessary, because adequate anesthesia does not require burst suppression. But I think too light of an anesthetic is not a sufficient anesthetic. And I think the replacement of anesthetics with muscle relaxants is not a way that I would practice. I would rather continue what we're doing right now. As I said, for children, I would advocate for a combination of adequate anesthetics with adequate pain medications that are provided in parallel with the anesthetics. And I would also provide vigilance about the possibility of delirium postoperatively. And I would provide adequate homeostasis during the surgical procedure and the post-op period to optimize the conditions as best as possible. And then the adequate response to us not knowing what the issues are is to do more research in that field.